is the clinical feasibility for same-day HER2 phenotype detection by PET. So thank you to the organizers of today's event, and thank you for those in attendance. So our approach stems from the expectations of what is popularly called precision medicine, which are to dramatically change patient care via individually tailored therapies and diagnostics, and as a result, prevent disease and improve survival. So these bullet points here kind of explain this a little bit more. So in general, precision medicine uses omics technologies and platforms to provide genomic, transcriptomic, proteomic information. Well, my focus is on cancer. So as I said, the aim is to guide treatment decision making by predicting tumor response to match agents targeting driver molecular aberrations. So although this rationale is clear, solid evidence of clinical benefits is challenging or ongoing. So that's to say that precision medicine is yet widespread in standard practice of care. So how is imaging integrating itself, and why is imaging useful? So I like this quote from a 2016 symposium of the International Society for Strategic Studies in Radiology, biomedical imaging and imaging guided interventions, which provide multi-parametric morphological and functional information and enable focused, minimally invasive treatments are key elements in the infrastructure needed for precision medicine. So this basically says that imaging can provide molecular information in a non-invasive manner, which could really be advantageous to precision medicine to support or synergize with the omics information. So the most advancement has come from radiomics, which is a method for the high throughput extraction of digital features from medical images, as seen in this figure below, and then using AI or artificial intelligence to turn these features into valuable medical information. So basically, the radiomic information is then integrated into algorithms that include the genetic and clinical information to turn out precise information on patients' prognosis, either good prognosis or poor prognosis. So how is PET imaging, how does classical kind of nuclear medicine fit? So nuclear medicine is currently positioned, it's utilized widespread in hospitals around the world to provide either anatomical, functional, or molecular information with the primary purpose of lesion detection. Nuclear physicians basically look at PET scans and make differential diagnosis from observations of looking at uptake of radio tracers inside tumors and consider that uptake in relationship to the background uptake in normal tissues. So what has molecular imaging done? It's added value in comparison to just radiology. So how it works is that basically you inject various radiopharmaceuticals against specific disease-associated proteins. These radiopharmaceuticals will target these disease sites that express a certain target. They'll accumulate within these targets, and then what ultimately happens is that this molecular targeting approach results in kind of high contrast, which means tumor to background ratios, images. So these high contrast images are used to detect tumors, make quantifiable data. So as like the amount of radiopharmaceutical that accumulates in the tumor can be kind of separated into high, medium, and low, very simply, and these can be associated with predictive values. And most importantly, actually is now guiding patient management. So you can provide the appropriate therapeutic pharmacological intervention. Now, this is in line with precision medicine, yet this is not integrated into these algorithms or in this AI system. So certainly, right now, you can select a single radiopharmaceutical for a single target. So these single kind of phenotype information can be incorporated into an AI system. But what we're doing is a little bit different, and I'll get into this right now, starting with the next slide. So basically, here's a periodic table, and highlighted in yellow are various elements that in their radioactive forms emit what's known as a positron. So a positron, I want to mention that each radioisotope also has its own physical decay half-life and unique coordination chemistry. So these add complexity to kind of when you want to inject a pharmaceutical that targets a certain receptor that's overexpressed on a tumor. Well, you need to kind of be each pharmaceutical kind of is has to be kind of it's unique in terms of like which radioisotope you can use and what coordination chemistry works for conjugating the radioisotopes to the pharmaceutical. Okay, so basically what's PET in short is a patient here on the left will get put into this scanner, and it's usually you can't tell what's going on in the scanner because of this plastic hardware covering it. But if you remove this layer, it's essentially a ring of detectors. And basically the way it works is that a radiopharmaceutical is injected a certain amount of time. This is going to be important for this talk. A certain amount of time needs to be, you need to wait a certain amount of time so that the radio tracer will be metabolized and cleared, and you also allow it to target and accumulate within the tumor. And here it's showing that it's in the brain, so that you can get a nice high tumor to background contrast, so that when the radiation starts to be emitted, the focal points will come from the tumor and not from the background. And this is important. So essentially how it works is that the radioactive element has an unstable positron that gets ejected. It travels a certain amount of distance. This you cannot control, but it'll travel a certain amount of distance depending on how energetic it is. So somewhere in the atmosphere, it just interacts with an electron and collides with the electron and forms this event called annihilation. So this positron then becomes two 511 keV gamma rays that are ejected in opposite 180 degrees directions, and the detectors on the opposite sides have to simultaneously be hit, and that's how the camera starts to register an event. So the problem here is that PET imaging technology is unable to differentiate simultaneously injected multiple radio tracers. So that's unlike SPECT, where its technology can differentiate the different energies of the gamma rays. PET technology is reliant on this kind of system of annihilation that forms 511 keV. So you could have multiple radio labeled tracers against different agents to really do a multiple phenotype interrogation of tumors, which is in line with precision medicine. But unfortunately, PET cameras today aren't able to differentiate that because they're all going to annihilate and form these two 511 keV gamma rays. So what's the need for approaches to evaluate multiple phenotypes? So I'm going to talk about breast cancer and the tail of estrogen receptor and HER2. So basically, most individual breast tumors express the estrogen receptor, and these tumors are managed very well by oncologists because there's several available hormonal therapies. HER2 overexpression, though, is associated with a poor prognosis. However, it's been just over a decade or so that treatment has greatly improved, and that's with anti-HER2 targeted therapies like monoclonal antibodies like trastuzumab or pertuzumab. Um, Half of HER2 positive breast cancers, though, also express ER. And so in these cases, the doctor will always rely on the targeting HER2 with the most to target the most aggressive cancer. Excuse me. Okay, sorry about that. So, okay. However, breast cancer biopsies of local or distant recurrences have resulted in ER and HER2 expression discordant from the original primary tumor. So basically, that means that there are a lot of cases where the primary tumor will be ER positive or HER2 positive, but the metastatic tumor will be the opposite phenotype. In these patients, shorter survival occurs. And so the American Society of Clinical Oncology has recommended that physicians biopsy accessible metastases and perform immunohistochemistry when possible. However, metastatic lesions, as we know, are not often accessible because they're either unknown, they're occult, or the biopsies are in the brain or somewhere that you cannot access. So, in addition, there's this phenomenon called the ER-HER2 phenotype switch, and this is due to selective pressure from targeted therapy. Essentially, the most common form is where um, ER-positive tumors will eventually become resistant and phenotype switch to an ER-negative and then express HER2. So, um, although the two phenotype informations can be incorporated into an AI system, the point is that we like to develop a dual tracer protocol that is feasible for clinical application. So essentially, this is kind of a schematic of what we want to do. We want to be able to kind of somehow inject two tracers and develop a method that we can still stratify patients either with having all ER positive, a mixed phenotype, or all HER2 positive. And then we can better provide doctors with this type of information here, like all green or all red, or there's a mix. The problem is the time. Current clinical nuclear medical departments in North America don't work this way. They basically will schedule a patient to come in for a scan, and then the patient will go, and then there'll be a long time that goes in between where the patient may receive another scan. So this becomes really impractical for oncologists to kind of make uh, uh, an accurate decision on which way to go. If there was a method that where a patient can come in and have in the same day the two phenotype information, we believe that this would significantly improve uh, the physician's power to treat the patient better, and the outcome of the patient would be better. So the story with us is that we work on this molecule 4-fluoro 11 beta methoxy 16 alpha fluoroestradiol, radio labeled with F18. So for short, we call this 4-FMFDS, and it targets the estrogen receptor. So this is just a comparison of the molecule, the normal estradiol. This is the classical one that is being used in Europe and in North America right now as the like current state of the art ER targeting PET imaging agent. It's basically estradiol, however, it has an F18 label to it. And then we have developed this analog called 4-FMFES. On the right, you see the crystal structure of the estrogen receptor. So what ends up happening is that the estrogen receptor binds in these two pockets. And so what we found is that our 4-FMFES has equivalent binding affinity. So what makes it different? Well, what makes it different is that this methoxy and this actual other fluorine group that is not radiolabeled provide protection from hydroxy dehydrogenation and non-specific binding to plasma proteins. So this means that the normal FES gets degraded and the specificity is reduced, while ours is protected from degradation and is allowed to more specifically accumulate in the tumors. So what does that result in? That results in this comparison, this clinical study that we've done here. So on the left, you see a patient with a primary breast tumor here, and you see FES. So the injection site is here, and this is the normal metabolic clearance route. It's basically hepatoclearance, biliary clearance. So as you see here, just if you can do a very quick qualitative comparison, you see that the background is much cleaner with 4-MF-FES compared to FES. So as a result, you get a higher contrast and detection of the tumor. To show more about this, you can just see comparisons of patients injected with FES versus 4-MF-FES. You see that due to a higher background clearance, you can start to detect smaller foci. That's like right here in the red arrow. You get an overall better targeting of smaller lymph node metastases as well. So this can be seen on coronal as well as transversal images here and here. And then here you can really see that in detail that we can pick up micrometastases that are confirmed on just an anatomical imaging of CT. So in conclusion, 4-MF-FES has the ability to detect ER-positive tumors with increased sensitivity and superior contrast relative to FES. So the next targeting vector is an antibody, an IgG. So we're going to work based off work from our collaborators, Dr. Gary Olner, when he was at Sloan Kettering Memorial Hospital in New York. So essentially what you see here is you see the crystal structure of an intact antibody. These two areas are the areas that recognize and bind, but it's a very large molecule, 150 kilodaltons. And this area here, which is called the FC, is important for circulation. So in general, what Dr. Olner ended up showing the power of radiolabeling trastuzumab with another positron emitting radionuclide called zirconium-89. This was specifically matched with an antibody because the antibodies have a long half-life and zirconium-89 has a much longer half-life than F18. So what you see here in A is the immunohistochemistry of the primary tumor, and the red is supposed to be HER2. And so as basically you see, there's basically no red. This is considered HER2 negative. However, though, when they injected the patients, you see HER2 positive metastases present. So this is the power of nuclear medicine imaging. And then these metastatic tumors were biopsied and immunohistochemistry stained, and you see that the red is much more present than in the primary tumor. So this is what this demonstrates is that using a radiopharmaceutical as trastuzumab, an antibody, it's able to detect occult metastases in HER2 positive tumors where the primary is HER2 negative. So this is like something that can really be integrated into this precision medicine approach. So what we ended up trying to do is we ended up trying to do a practical approach to integrate both these radiopharmaceuticals. So essentially, we weren't trying to reinvent the wheel. We were trying to actually just be realistic and find a way that we could integrate both these into the clinic at the same time for a patient can go into the clinic on the same day and get both these scans done. So we started with preclinical studies, and we had mice that were bilaterally implanted, one with its tumor red that was ER negative but HER2 positive, and the blue tumor, which was ER positive, HER2 negative. And we set up a system of protocols, and the one that we found was the best, uh, for obvious reasons, is that we start with the 4-FMFES F18. That's because the F18 has a very short half-life. After 24 hours, all the radioactivity will decay, and this is a small molecule so that it gets metabolized very fast. So we injected this on day one. We did our scan about 1 hour after injection to let the tracer clear and accumulate. And then immediately after injecting these mice, we injected with zirconium 89 trastuzumab. And then we did scans at 48 hours post-injection and 144 hours post-injection. But in reality, what it meant is that we ended up having to go from 1 day out to almost a week. So on the right, you see the scans. So before we scanned these patients with before we scanned these mice, injected them with our agents, we did a standard F18 FDG, which is the most known radio tracer for breast cancer. So the problem with FDG is that it provides metabolic information, not molecular information. And so what you see here is basically the problem with FDG. You see that it has a high background due to kind of some tissues have high metabolism for FDG, whereas the breast cancer really has modest uptake, and that's just due to its inability to kind of accumulate FDG. Well, what you see here now is the mouse on day one, the tumor red that is ER negative is blank, but the ER positive tumor is bright. And then this is standard hepatobiliary elimination. And then in zirconium, in the mice injected with the zirconium 89 trastuzumab, you see the opposite. You see that the HER2 positive tumor is lit up, and the HER2 negative tumor is not. However, you do still see a lot of elimination, a lot of background. So we had to wait to day 7 to really get these high contrast tumors that we really would need to have in order to get this into the clinic. To look at this differently on a graph, you see that the uptake, the solid line, steadily goes up when we increase time for the antibody, but the blood clearance slowly eliminates. So you don't really get this high tumor to blood or tumor to background ratio until well out to 1 week. Well, that's just not good enough because we're aiming at 24 hours, where you actually see that there's more activity in the blood at that time than there is in the tumor. So how do we deal with that? Well, in conclusion here, from a proof of concept, we were able to selectively discriminate for ER positive or HER2 positive tumors. Both tracers outperformed F18 FDG. However, we have this long wait period of happening. So what we ended up doing is we did antibody engineering. So we wanted to retain the single chain FD aspects, but we removed the non-essential aspects. However, we had to deal with this FC. The FC is important because it binds to this receptor known as FcRn, which is the reason for antibodies having long circulation half-life, because it'll bind it, take it inside the cell, but recirculate it back out into the bloodstream. So what we ended up doing is we basically engineered this area, the FC, and we identified amino acids here in hot pink that bind the FcRn receptor, and we mutated them. And so essentially we developed this kind of fragment here, this single chain FDFC. And why we did this one is because anything below kind of 80 kilodaltons, you're going to eliminate too fast. And long story short is that this molecule here, especially with the mutations, we can still get a good amount of uptake comparable to an intact antibody, but get a lot faster clearance in the blood. So here in a different model, you see the difference here. So you see the single chain FBFC, but wild type. So it has these not mutated. You see that you get this long blood clearance, and this is typical of a normal antibody. But if we put in these two mutations called H310A and H4035Q, you see that the clearance drops a lot, the tumor uptake is a lot, and we can feasibly get this down to by 18 hours. So the only piece, because forgot to disclose my alliances with commercial technologies. So unfortunately today I can only show you that we have made the wild type single chain FBFC. We've made different variants, one incorporating H310A and one incorporating these two key double mutations. So we believe that this is going to, so we're currently radio labeling and same day imaging evaluation is in progress. So we're going to radio label these with copper 64 because copper 64 has 12.7 hour half-life. We're going to incorporate these into our ER/HER2 imaging protocol and ultimately determine if ER and HER2 can be discriminated in 1 day from initial injection to last PET scan. So I'd like to acknowledge my center at the University of Sherbrooke. It's called, short for SIMS in French, it's Centre d'Imagerie Moléculaire de Sherbrooke, or the Sherbrooke Molecular Imaging Center. We have a fully functional center from discovery all the way to late clinical phase. These are the key people that have helped with the work thus far, and thank you very much.